Good afternoon, everyone. My name's Helen Whitby. I'm a Senior Democratic Services Officer for Dorset Council. The first item on this afternoon's agenda is the election of chairman. Please could I have your nominations?
It's Councillor North over here. Could I propose Councillor Jill Haynes as chair, please?
Thank you very much.
Councillor Bill Pipe would like to second that.
Thank you very much. Are there any other nominations? Councillor Haynes, would you like to take the chair then, please?
Thank you very much, Helen. Thank you for that. Next on the agenda, although I don't think it is actually on the agenda, but I propose to do it anyway because if anything crashes, we need to have a vice chairman, and I'd like to propose Lisa Northover as that. Can I have a seconder, please?
Yeah,
yes,
Rebecca.
Councillor L.J. Evans.
Rebecca, is that you?
Yeah, I can do that, please. Thank you
very much. So, Lisa, is that okay?
Yep, thank you very much.
And do you want to put your video back on now so that we've got both of us up? Yeah, I'm here. Okay, marvellous. I'm glad you're doing that because I can't get into my iPad for the agenda, which is quite complicated. The next item should be apologies, which seems to be have escaped the meeting, and we have got some apologies. Would you like to read those out, please, Ellen?
Yes, we have apologies from councillors Cheryl Johnson, Emma Parker, Roberto Rocca and Ryan Holloway.
Okay, that's great, thank you. And then next on the agenda is declarations of interest. Is there anybody who requires to declare a declaration on any of the items that are on the agenda? Of course, you can always raise that when you go forward. I think we've got three. So Councillor Orrell to start with.
Thank you, Chair. So I declare, as I have done in our Dorset meetings, but for the benefit of Bournemouth, Poole and Christchurch, that I'm a practicing GP in the NHS and also hold some contracts for public health through the Two Harbours Healthcare. I have a dispensation for that to allow me to participate. Thank you.
Okay, thank you. Councillor Nick Ireland.
Yeah, I'd like to declare an interest. I'm a governor of Dorset Healthcare as part of my councillor role. Did you hear that?
I heard you, Nick. Who else have I got on here? I've got Councillor L.J. Evans.
Yes, I'm also a working GP and a bank employee of Poole Hospital NHS Trust.
Okay, thank you. Councillor Chris Matthews.
Yeah, thank you, Chair. I'm also a governor of Dorset University Healthcare Trust.
Okay. Now it's saying I've got Councillor Andrew Kirby.
Yes, thank you, Chair. My partner is a district nurse under Dorset Healthcare University NHS Foundation Trust, and again, I have dispensation granted to me through Dorset Council.
Thank you. And Councillor Hazel Allen.
I'm employed by Royal Bournemouth Hospital, but I have a Dorset-wide remit as a consultant nurse in liver disease. Thank you.
Okay. Are there any more declarations of interest? Okay, good. Just a few bits of housekeeping, please, to start with. If you could all bring up the meeting chat bar by using the toolbar that is in the centre and use the chat box. You can either use that if you wish to speak, or you can put a hand up, although I can't always see everybody who's put a hand up, so it's sometimes easier if it's on the chat bar, because that means I get you in the right order when I call you. We are on a very tight timetable here today. We have 2 hours for the meeting, and so if there are questions, that's great, and we're looking forward to questions. But if you just want to make a comment during the process, could you use the chat bar for that? Could you also remember that the chat bar is open to the public, and therefore you need to be aware that what you write in the chat bar could be available for all to see. So please don't use it as if it was Twitter. The The next item is to look at the terms of reference for this meeting, which is to scrutinise the NHS and health response to COVID-19 across Bournemouth, Christchurch and Poole Council areas. I have been very pleased to see quite a number of questions from members of the public come in, and they have all raised areas that I'm sure we would, as councillors, be concerned with as well. And for that reason, I am not proposing reading out all of those questions at this moment. I'm proposing moving right into the presentations and then reading out the questions and their answers at the end, because I think many of the questions will have much fuller answers by the discussions that we are going to have during the meeting today. So I hope that that is all satisfactory for everybody who's at the meeting. Could we just roll the agenda up through, please? Okay. So therefore, we are going to item 5 on the agenda next, which is to receive a briefing from the Director of Public Health. So that's Sam Crowe. You there, Sam?
Good afternoon, everybody. I'll just bring my screen up and share my presentation with you.
Got a nice view of Lisa. Hello, Lisa. Great, thank you.
Okay, can you all see that? Is that coming up clearly?
Anybody not see it, would you please flag? Okay, sounds like good to go.
So I've pulled together a fairly brief presentation for members of Joint Scrutiny today, just to remind us of where we've been as we've gone through this pandemic. It's just intended to provide a little bit of background and context before I perhaps then break and focus on some of the next steps. So in terms of the national context, just a reminder of some of the timelines. On the 30th of January, WHO declared that COVID-19 was likely to be a public health emergency of international concern. And we had the first 2 index cases recorded late January in the UK. And it wasn't until late February that WHO classified the UK where we had evidence of local transmission. And I remember, I think it must have been the week before, briefing both council chief executives about the likely impact of COVID. We'd had a briefing from the Regional Director of Public Health, and it had become clear that this was likely to be quite a significant incident for councils. So around about that time, the public health team started supporting both councils' incident management teams to go through business continuity planning, starting to look at the likely impact on critical services across both councils, and NHS partners were starting to move into a similar mode of action. 10th of March was the point where the contain phase of the national strategy couldn't realistically be maintained purely because of the number of cases and contacts being generated. It was felt at that time that Public Health England wouldn't be able to maintain the level of contact tracing that had previously been carried out. So we moved into the delay phase. 23rd of March was when Boris Johnson announced the lockdown measures, and the 30th of March was when we passed the 20,000 cases mark in this country. It's worth pointing out that testing was very much focused around people who were being admitted to healthcare settings, hospitals in particular, around this time. So that national tracking of cases was very much an underestimate. This was based on the results of what's called Pillar 1 testing, which was being used at the time to focus on our understanding of COVID in hospitals. April and May was our peak incidence in the country, and May to June, we then started to see the impact of those national lockdown measures, and we began a slow decline, both in number of cases and also in the number of deaths linked with COVID-19. And in June, we began a phased easing of lockdown measures, and we've moved back into the widespread implementation of NHS test and trace, and the National Contain Strategy. And the final point in this slide is to acknowledge that on the 30th of June, which was yesterday, both councils published their local outbreak management plans. That's a requirement for all upper tier councils to have those in place. And these plans set out how we will work closely with Public Health England and NHS Test and Trace to make sure that we've got the resources in place to be able to respond to any local outbreaks quickly and effectively. So my next slide is just really a snapshot from the national system. This is the weekly surveillance report that Public Health England put together, just to give you a sense of the cumulative impact of COVID. So the blue figures down the bottom show that the total number of positive COVID cases that we've had from Pillar 1 and Pillar 2 are rapidly approaching the 250,000 mark. There have been a huge number of people tested, 1.3 million and rising. And also, unfortunately, we're showing on there the national figures for the number of deaths. Important to understand that that's just where the deaths have been linked with tests that have been carried out through Pillar 1 and Pillar 2. There's also the additional excess mortality through death registrations, and there have been calculations, obviously, by the Office of National Statistics, which puts that figure a bit higher for this country. The next slide is just a reminder of the epidemic curve nationally. I think it's worthwhile looking back on this just to understand just how quickly things escalated. So this is a week by week progression of the number of cases confirmed through Pillar 1 testing in green, and as Pillar 2 testing, which was the national testing capability, came online. Those are the yellow bars. You can see the shape of that epidemic curve rose very, very steeply. And I think, obviously took a lot of us by surprise. And I think it's worth just bearing that in mind, because now we're back into a situation where luckily we've got very, very low numbers of cases and we're back into that contain phase. It's just a stark reminder of how quickly things can escalate if we don't have a good grip on understanding our local transmission. Cases and contacts can grow very, very quickly. My next slide is just a look through the impact in Dorset in terms of COVID-19 deaths. There are two charts being shown here. Apologies if you can't see the detail, but they are available through the Public Health Dorset dashboard, which is circulated to partners in the system briefing. This is a live dashboard which updates through two sources. The first chart is based on COVID-19 deaths as reported by hospital trusts, and also the deaths that are reported from care homes to the Care Quality Commission. And you can see through the different coloured bars that the pandemic started to change in terms of the mortality impact. Very much in the first phases, we were looking at deaths recorded from hospital settings, but as we got into the middle of our peak in Dorset, unfortunately, we had a lot of outbreaks in care homes, and you can see the blue bars there are deaths in Dorset care homes, and the orange bars there are deaths from care homes in BCP Council, and that started to take over and became the main source of deaths from COVID-19 in the second part of our local peak. The graph below that shows you the ONS registration data, and what we've done is we've separated out the overall deaths notifications, which are in orange, from the notifications where they've recorded COVID-19 as a contributing factor in that death. So you can see right in the middle of the pandemic there, it was having an impact, not just in terms of those COVID-19 deaths, but you can see from the smooth lines that there's also a suggestion that our overall mortality was above the 7-year average, which we've depicted in this grey line, which runs across. That's the 7-year average for our usual expected mortality in our system. So we did have several weeks where our local mortality patterns were very much above what we would expect to see for this time of year. My final slide, or the final couple of slides, really about looking forwards. Luckily, we've got very low numbers of cases at the moment across Dorset and BCP Council, and also across the Southwest region. So the system briefing I've been sending out, we've been talking about 3 confirmed cases in Dorset, 3 confirmed cases in BCP Council in the past 5 days. And we're looking at around about 7 to 9 positive cases per day across the whole of the southwest region. So it's a very, very different picture to where we were 4 to 6 weeks ago. We're still not clear about the impact of some of the visitors that we had to tourist hotspots, particularly during last week's spell of hot weather. For that reason, I'm quite concerned that we maintain enhanced daily surveillance. We're getting good information now, both from Public Health England and nationally, and we scan that regularly just to make sure that we're on top of any changes to our background pattern. And anything that we would pick out as being different would then be focused through our 2 local outbreak management plans, which are now in place across both councils. We work very closely with NHS Test and Trace to respond to complex cases, and I'd just like to stress that there hasn't been much change really in terms of how councils have been working alongside Public Health England, particularly around cases linked to settings like schools and care homes. Throughout the pandemic, we were receiving notifications from Public Health England of cases in care homes and outbreaks in care homes. And so we've managed to have a lot of experience in working in a multi-agency context around the sorts of response and support that we offer when we have those outbreaks on our patch. We've been provided with the Test and Trace grant to the value of 3 million across the 2 councils, and that money is being used to develop resourcing and capacity plans to support our efforts as we go forward. And I'd just like to also make the point that it's important people realise that public health action is really focused on rapid testing of people with symptoms and prompt isolation of contacts to break transmission. The reason I mention that is there's been quite a lot of discussion about frequency or regularity of testing, and should we be doing widespread testing in settings, and particularly high risk settings. I think our view at the moment is it's important to focus use of public resources where we've got real evidence of COVID, rather than testing large sections of the population, because we don't want to give a false sense of reassurance that if you've had a negative test, it means that COVID isn't around. So in line with Public Health England guidance, we respond to symptomatic cases, arrange to get those tested quickly, and that's the basis of our public health action and prevention measures. We are still living with COVID, so even though we've got low numbers of cases, the messages that I've been trying to give out through talking to various media over the past couple of weeks are that prevention measures are still important at the population level. So we're still saying, please keep the hand washing going, and social distancing is really important. Even if you think that the current situation is low risk, it's how we continue to keep the risk of transmission as low as possible. And then my final slide is really about contact tracing, because I was asked to perhaps provide some insight into the contact tracing work and the app. At this point in time, the national effort is very much a telephone-based contact tracing service. CTAS is the contact tracing advisory service. It works at 3 levels. The first port of entry to that now is through either dialing 119 if you're symptomatic and asking for a test, or visiting the portal on the .gov.uk coronavirus site. There are 3 tiers to this service. Tier 3 is the nationally recruited call handlers that manage the initial symptomatic callers. They arrange testing and interview contacts. Anything that looks remotely complex is bounced up to Tier 2. These are people with professional backgrounds in health, and they handle some of the more complex issues that might be raised by Tier 3. Tier 1 is the part of the service that I'm most interested in, because that's the regional health protection team based at Public Health England. So that's the team that I have very close connection with. Rachel Partridge also connects regularly through the regional health protection network. This is our early warning of any contacts or cases that are identified in complex settings. We get a call straight away, and that's the route by which we start to develop our response through our outbreak management plans. We are providing 3 or 4 people from the public health team who support that service. So there's a sense that we've got really, really good cooperation and joined up working, certainly within the southwest region. And I've got a lot of confidence in that arrangement going forwards. So just a quick reminder, anyone fulfilling the contact definition criteria will be asked by that service to self-isolate for 14 days. And we will be increasingly using information from Test and Trace to develop our response through the local outbreak management plans. And it's just worth making that link back into contact tracing. Anyone who's asked to self-isolate, who may be concerned because of their family circumstances or the domestic situation, we need to think through in our local outbreak management plans how we can start to offer a bit more support to people who are required to self-isolate to keep the adherence with that public health action as high as possible. So some of the support that both councils stood up through support to people who are shielding, for example, working closely with voluntary and community services, we need to think through how we continue to maintain that for perhaps in a more targeted way for people on our patch who are asked to isolate. So my summary is we're in a good place. Agencies worked really well together to respond to COVID-19 based on what we knew at the time. I provided a bit of background in the one-page briefing that went out to members around that. We know a lot more now, and more resources are in place for us to be able to work effectively to contain the virus. So we've got a much enhanced testing capability, and thanks to everyone who is involved in standing up Pillar 1 really quickly, and also the links with the national testing offer through Pillar 2, particularly the mobile testing units and the regional testing service has worked really well on our patch in Dorset. But COVID-19 is still here, it's among us, and we do have to learn how to live alongside it safely as we open back up and think about recovery. And my final sort of thought is that events in Leicester over the past week or so show we can't really be complacent, and we need to be ready to respond quickly should the situation change. So that's my presentation, members. Happy to take that down.
Thank you very much, Sam. Could you just elaborate a little bit more about, and we talked about test and trace, but could you elaborate a bit more on the app that they've been testing the Isle of Wight that everybody's got very excited about that doesn't seem to be happening?
Yes, I don't think I can elaborate much more than your introduction, Chair. The app was, as you say, piloted on the Isle of Wight. I believe that all sorts of issues around governance of personal data have meant that it's been decided that's not the primary focus at the moment. And actually, it was better to get a national telephone-based service up and running. That's the sort of bread and butter approach to epidemiology that a lot of the regional field service teams are familiar with through Public Health England. So to have that national telephone-based support to be able to handle some of the volume, I think was quite a smart move. If we placed our reliance in an app, we could have been waiting quite a long time until that project and that product was ready to go. I still believe they are planning on bringing something forward, but I've not heard anything recently about timelines for that. For now, we're going with the national telephone-based NHS test and trace service.
Okay, thank you very much, Sam. I think what we'll do is after each presentation, members of the committees, we'll just take a few questions now. And I've got, first of all, I've got Councillor Bill Pike who would like to ask a question, followed by Councillor John Orrell.
Thank you, Chairman. Thank you, Sam, for a very comprehensive brief. The 119 number, is that widely known to the general public? Because it seems quite new to me.
I hope so. I know that there's been a lot of there's been a national media campaign. I've been watching a bit of the football. I've noticed it's on the billboards around the grounds through televised Premier League games. I've certainly seen adverts on the television advising people that the main route now to testing is to call 119 or to go through the www.gov.uk coronavirus portal. But you're right, it is a new number. We've been doing local comms to amplify and fall in line with that national messaging. So whenever we've got an opportunity, we're trying to say to people that that's the consistent route into the service. The more we can get the bulk of people who have symptoms to go via the national test and trace service, the better the data will be coming back to local areas. So it's really important we have that sort of one way in and one way out to the service. But yeah, I'd be interested in other people's views as to whether that number is widely known. It may be that I'm just very primed to it, so I notice it. But there has been a national campaign.
Okay, Sam. On that one, I'm not sure whether I actually asked or not, but how long has it been up and running, the 119?
So the service was launched on the 28th of May. So we've had about a month or so of running. I know that
I need to get out more.
We've got another opportunity through local outbreak management plans again to amplify that. So as some of the services are changing across the councils because of the changes in the shielding announcements, we've got another opportunity to start to make those contact numbers very, very clear. So we'll be doing more work on that over the next few weeks, almost certainly.
Well done, Sam. Thank you very much.
Thank you.
I have to say that I wasn't aware of that number point as a health scrutiny chair. Lisa is shaking her head as well as a health scrutiny chair. And I also say I was maybe one of the few people who actually had to go and be tested for COVID because I was very poorly. What a rubbish system that on the line is, because they send you back a text message with numbers which don't work. I tried it 4 times when I was feeling really poorly and ended up actually having to phone and wait for 3/4 of an hour on the phone to get to speak to somebody before I could get it processed. So that system is really not fit for purpose. I now have Councillor John Orrell followed by Councillor Robin Legg. Will the rest of you, if you've heard of the right, we won't do it that way round. If you've actually heard of the 116, would you put it up on chat? Otherwise, we'll assume you haven't heard of it. And we're now going to go to Councillor John Orrell.
Thank you, Chair, and thank you, Sam, for that presentation. By way of preamble, I was to say congratulate Dorset, the Public Health, the Council, the way it's coordinated voluntary services and the NHS locally. We've done everything that's been asked of us. So if I can say that at the beginning, and we have a very good, well, a favourable death rate compared with others. So there are many things which we can be proud. So in making some points, I'm not trying to have a go at anyone. My point is, rather than go backwards, this is a pause. I see it as a game of 2 halves. We're about to go into the second half, and it could be quite a nasty second half. We just don't know what the autumn brings. So are there any lessons we can learn at this stage so we could do better? So if I could, on the point of testing, this week's BMJ, world leaders in COVID, it goes through countries that have performed well. We have the luxury now of looking at around the world at countries that have done well and countries that have not done well. Sadly, despite our best efforts, we have not done well internationally, one could say. Other countries with much poorer funded health services have done way better than us. Some African countries, for example, and they've done it by really good testing, using local teams, sixth formers, college students and the like, actively going door to door, tracking down cases, isolating. Really, it's basic public health stuff, really. I'm not teaching you to suck eggs. So my plea, and it really is a plea, is please can we just get our testing right locally, even if we have to bend a few rules nationally or ask permission from our bosses on high. Can we not use our local resources? We have 750,000 volunteers. We didn't use them. We've got GPs. I spent 35 years treating infectious diseases. I can't test for this. I can't advise my patients. We've got environmental health teams whose reason for being, they track down food poisoning. You track down meningitis. You tell me to prescribe antibiotics. We work together, public health, primary care. We've done this for decades, and suddenly, with our worst pandemic ever, we're not doing any of it. And it's such a tragedy. So please, can we get local testing, tracking and isolation?
So shall I come back, Chair, very quickly? I don't want to...
You're muted, Jill.
Sorry. If you could, Sam, I've got 3 more people on the wanting to speak, and then I'm going to move on to the next item on the agenda. But if you could just answer that one for Councillor Orrell, please.
Yeah, I don't disagree, and there's a lot of look back going on. I would just like to assure members of Joint Health Scrutiny that through the local outbreak management plans, directors of public health will be able to direct local testing capability. So we've got the capacity now. We have the ability to set aside local testing to be able to respond to outbreaks or where we feel it's needed most. So it's very much, I would agree with John's characterisation of this as a game of two halves. For us in the public health team, we feel like we're now stepping forwards because we were often just reacting to what was going on nationally. Now we've been given the tools, we've been given the resources, we've been given the mandate at upper tier council level to go out and really make that contained strategy work on the ground. And we are going to be the first line of defence locally against having to go back into national lockdown. So it is very much at the forefront of our minds, and we are working very, very closely with PHE and other colleagues to make sure that those plans are in place.
Right way round. I'll mute myself. Councillor Lisa Northover, and then I have Councillor Legg.
It probably follows on from the previous question. I understand that you want to direct the resources to people that have got symptoms, but I just wondered if we've identified proactively places, and Councillor Legg was going to say about meat factories, for instance, or do we have we looked to see the sorts of places that are most likely to have problems so that we can perhaps, when we do have enough capacity, proactively go and test and see?
Yes, thank you. We do have a list of high-risk settings, and the COVID-19 Health Protection Board, which is our new health protection board under the outbreak management plans, is working through how we exercise against those action cards so that we've got a very clear understanding of what to do and how to respond quickly. I think just coming back to this issue of widespread testing among people who are asymptomatic, it begs the question of how regularly you're going to test, because the risk is you go into a setting and you test once, people come back with a negative test. When's the next period of time when we should be going back in and testing? And if you're not careful, without a clear strategy, you're either giving false reassurance that you've tested negative for COVID, but that was only on that day. So we don't yet know enough about what would be the frequency of testing. If we had the capability to do regular weekly testing, would we consider that to be a good use of the resource? So at the moment, the Public Health England and the scientific advice is absolutely, when there is a case, we would go into a setting and we would do widespread testing to identify the level of asymptomatic transmission. So everyone connected with that setting would be tested. But until we've got a recognised outbreak where we're responding to positive cases, it's a real needle in a haystack situation, particularly when we have a low number of cases at the moment. Obviously, if the situation changes and we're into a situation like they're dealing with in Leicester, where you've potentially got community transmission going on again, then there may well be situations where we would escalate and we would say we are now in a situation of greater concern. We would like to do more widespread testing in the following communities. But until we have that intelligence, our current approach is to respond to where we know positive cases are, get them tested quickly, isolate the contacts, break the transmission quickly that way. I think you're on mute, Jill, again.
Yeah, thank you. I just couldn't get the mouse to move. Lisa, does that answer your question? Yeah. Okay. Thank you. Councillor Legg.
Thank you. You've partly answered some of that, Sam. I think at one time my electoral area changed, and it's not in my area anymore, but there was quite a significantly large abattoir and meat processing facility in the Epminster area. And I remember from way back when there was a foot and mouth outbreak, a lot of farmers got very exercised about the fact that significant numbers of people who worked in the factory were being bussed in as agency staff from great distances away. And I'm wondering what you're going to do about those sort of facilities now, And if there is a test is carried out and it becomes apparent that there's been an outbreak, does that mean that you've got significant powers to shut those facilities down to stop the spread of an outbreak, or how will you deal with that?
Yeah, it's a good question. So very quickly, one of the things that we're doing is to link with neighbouring councils that also have outbreak management plans, make sure that we've got good ability to work across borders. So that's the first point. We are very aware that outbreaks won't necessarily be neatly contained within a Dorset or a BCP council border. I think the second point around powers, there's obviously been a lot of discussion, particularly off the back of what's happening in Leicester. We already have powers and work alongside businesses. Environmental health officers in councils are very used to working with businesses, and when there's clear evidence that there's communicable diseases that are linked with a particular business, they're very well used to working with those businesses, helping the businesses to close, do the necessary cleaning, and if necessary, the enforcement powers around that. I think the situation is obviously slightly different when it's not contained to a setting, and that's what they're grappling with in Leicester at the moment. So there is national work going on about how any national powers may be handed down to councils as a sort of tool of last resort, if you like, if we had to go back into a situation where we're asking people to stay off school, stay home from work, and go back into something that looks like a local lockdown. But that's being looked at by Cabinet, I think 21st of July, around about that time. It's a very, very live issue. My sense is that through the local outbreak plans, the role of political leaders is really important. So we have an outbreak engagement board, which works through the health and wellbeing boards of each council, and actually having very, very clear comms and engagement using our political leaders is a way that we can work with communities, be very clear and transparent about what needs to be done and what we're asking of people, and that powers and enforcement should really be a sort of last tool in the box, if that makes sense.
Thank you.
You're muted, Jan.
Oh, gone back again. Come on. No, somebody's unmuting me. Stop it. It's not me doing it. Somebody's doing it to me. Could you, first of all, I'd like to say thank you very much for the work that you've put into this, and actually the work throughout the whole outbreak, because it must be an absolute nightmare for you and your team. So we'd like to say thank you to everybody who has been working so hard throughout this. And we know it's not over. So, you know, our best wishes for all the work that you will have to put in the future. Could you possibly send the links to the 2 local management outbreak plans to the clerk, who will then be able to forward them to the members of both committees, and then that way they'll be able to look at those plans if they need to? Or could we have it so that the Bournemouth ones are sent to the Bournemouth councillors, and you see what I'm saying? Can we do that?
We'll arrange for that to happen, Jill, after the meeting. Thank you, Jen.
They're new, so we haven't really had a chance to look at them yet. So I think that would be of interest to both scrutiny committees. So if you could do that, that would be great. I know they are on the websites, but sometimes the websites take a bit of trawling to find those sort of things. So thank you very much, Sam. Thank you for your input today. I'm now going to move on to item 6 on the agenda, which is to consider a briefing from the Chief Operating Officer, Tim Goodson, from Dorset Clinical Commissioning Group. Good afternoon, Tim.
Hi, Jill. If I just share my screen first, make sure everyone can see this. Can I just check everyone can see the presentation?
Not available.
No, can't see it.
No, sorry, Tim, nothing up yet.
Hang on.
Yay, we're in business.
Okay, I'll start from there. So firstly, then I think it's only right I should sort of thank all of the NHS staff, volunteers, key workers, partners, and public who have been a tremendous help to the NHS over the past sort of 101 days as it is now. And clearly, our thoughts were also with all those people that have lost loved ones during this period, including some of our NHS colleagues. So what I'm going to do, I'm going to give us a very sort of rapid walkthrough of just some of the things that have been going on in the NHS and how we've sort of managed to sort of respond during this period. Firstly, as I sort of mentioned there, it's not just been about the NHS. This has been very much a multi-agency response, and we've been working as part of that team right across Dorset. And I think it's brought the various public sector partners together more so than anything I've seen in sort of 25 years in the NHS, and it's really felt that it has been a collective effort to effectively do this. So I just wanted to sort of formally acknowledge that and just give a bit of a flavour there on the slides of some of the resilience networks that are actually in place as we go through it. I'll pause on this slide for a while and just sort of go through and expand on some of the bullet points there, because it really starts to show sort of the level of stuff that is actually required to respond that we've seen really evolve over the last sort of 100 days. There has been a lot of national guidance issued, and that is predominantly what we've been following, and particularly at the start of the pandemic, it was coming out very quickly, very rapidly, and needed to be put into play. One of the first ones was really the emptying of the hospital beds as a sort of national instruction, getting ready for what was being predicted to be, quite a large peak in terms of the number of patients that we were likely to see. And we've also been preparing the hospitals themselves as well. So quite a lot of temporary building works were undertaken, really working how to segregate a lot of the hospital facilities. So if you go around, you'll see there's a number of sort of false doors, partitionings, different airflows, different walkways around. So all that went in quite early in the process. And there was a real focus on increasing the critical care capacity. So this was really the critical care beds, and it seems quite a long time ago now we were talking about sort of ventilators and are there enough within the system. But it was all about really increasing those critical care beds and having the ventilators for a predicted surge in patients to sort of come through. On top of that, clearly the NHS isn't set up on a day-to-day basis to deal with a pandemic of this sort of nature. So various Nightingale hospitals started coming up around the country, and in Dorset we were looking at the Bournemouth International Centre as a potential Nightingale hospital for effectively Dorset and Salisbury as well as part of that network, again to increase our critical care bed sort of capacity. It wasn't required in the end, and it only really got to the sort of the planning stage. We did, as part of this, stop at virtually all elective work that was proceeding, and this was really a risk-based decision in terms of the value of the actual procedure that was going to be undertaken versus the risk for the patient of contracting COVID or the staff as well in terms of carrying out the procedures. Similar was in play for outpatients, and effectively the face-to-face going into the hospital for your outpatient appointment came to an end, and it was more telephone triage, video consultation. Staff needed to be retrained on some areas as we moved staff around the hospitals, again to really bolster some of the critical care sort of facilities and getting ready for that sort of surge. This was repeated in the community hospitals as well, and we started to bring together effectively teams from across the NHS and local authorities to assist with some of the discharge planning and creating effectively a single team to start to discharge people out of hospitals. And as part of that process nationally, the continuing healthcare assessment process was effectively put on hold for the period. Similar with our GP practices, again, it was, can you call your GP first, or effectively use some of the e-consult technology that was there. And again, it would be a telephone call, video consultation, and really only bringing in patients into the sort of GP environment that was absolutely necessary to do that. And as part of that, a number of the practices through their sort of primary care networks set up what was referred to as hot and cold sites. So the hot site being where somebody potentially was showing signs or talking signs around COVID, and the cold site where it effectively wasn't a COVID related inquiry that was going on. So we've seen that go across Dorset as well. And a number of the additional services still continue. We still continue with all the home visiting, even with an increased amount of personal protective equipment that did continue. And we tried to supply as much sort of support really to some of the care homes as well as we went through. Now, as we actually went into the COVID sort of period, again at the start, there was a huge focus really on PPE requirements, so all the gowns, the masks, the gloves, and we have been through literally millions and millions in terms of the numbers of personal protective equipment that's actually been needed to do this, because they have to be frequently changed as you go through the day. So the actual stock control of this and the distribution of it has been effectively a small industry on its own, and there's been a similar sort of response with local authority colleagues and through the local resilience framework to effectively help again some of the care homes with this, and a wider distribution across primary and community care. We've touched on there through Sam the testing requirements, so I won't pause too long on that. But again, the testing has gone up and up, and we've just seen huge numbers of people actually swabbed and tested for this. As a key sort of response to the actual pandemic. As I mentioned, segregation within sites, we've done that with some buildings in terms of some of the primary care facilities, more difficult to do in the acute hospitals and at scale. But again, you can use sort of different entrances, different ways in, and try to segregate people as soon as they come in. So that has been going on. And we've also seen a large number of NHS staff effectively having to self-isolate in exactly the same way as the other members of the public, if they've been showing any signs, or if anyone in their household has. So that there has been a real pressure on staffing due to sort of having to stay at home, self-isolate as part of this period. I've touched on already there some of the face-to-face has moved on to sort of video consultations and using the 111 online and some of the e-consult, which is a similar web-based application for GPs. So use of technology has really increased on this, and any member of NHS staff that could work from home has really been following national guidelines to effectively do that, and we've encouraged people to work at home, and we were set up to do that pretty much from the start really. In terms of the workforce, again, if you recall, there was a call out to sort of members of the public, not just in volunteers, but also a return back to NHS for any sort of people that have previously worked in that, and we have made the most of that within Dorset. So we have seen staff returning. We've also shared staff around the different organisations, and people who weren't nursing, for example, as their sort of day job, but were a nurse. Again, they've gone through sort of inductions and they've been redeployed within this. So it's been really good to see the sort of the flexibility of NHS staff and really a call to arms to assist, and we've seen that right across the board. I was asked to touch briefly on sort of the financial implications of some of this, and I think as the pandemic has gone on, there has been a move to a focus on some of the economic impacts of this, which are clearly going to be enormous for the whole country. Right at the very start, we were effectively encouraging the NHS, if we could, pay any provider within 7 days, just as a mechanism to keep cash flowing through effectively the whole economy to do that. So we've done that. We followed suit in terms of support for care homes with a process to effectively apply for an additional 10% support. The whole of the NHS, which previously had been working on an activity-based basis with sort of invoices flowing around the organisations based on the number of procedures you do, moved effectively across to a block contract arrangement nationally. So effectively a certain period was selected and said, well, that's what the payment is, we'll just use that payment, and everyone simplified effectively the what is a quite complex NHS financial regime into a very simple sort of process to ensure, again, the cash moved forward and we weren't distracted debating sort of invoices and payment mechanisms, and it's really now being managed on a national level to effectively do that. We also provided cash forward into the acute trust 1 month in advance. Again, it was to make sure that everyone could really pay the bills and do everything they could do right up front. And you probably remember the Chancellor saying, the NHS will get effectively what it needs on this, and that was certainly a very clear instruction that came down, and everyone's responded to do that. I won't go through the other points there, and they're there for people to read, but it really has been a massive focus just in terms of let's spend what's needed, let's put in place what's needed, let's simplify and support everything, and let's focus on the real crisis that we've had, and that's been a credit, I think, to the whole financial sort of community within the NHS and just the way people have pulled together. A number of concerns have come out of this, and I think we've seen some worrying reductions in referrals. I think people have not really wanted to venture outside of their house, and we've seen quite dramatic drop in referrals, particularly around some of the cancer services, some of the children's services and cardiac services. And we've tried to sort of promote that throughout the campaign. The NHS is open, and if you are effectively suffering any of these conditions or concern, please do contact your GP practice or use the 111 online or phone 111 to try and make sure that we did capture it, but the numbers are down. We did see quite a prescribing surge at the start of this with people who were clearly concerned, who perhaps hadn't relied on some of their medication previously, wanted to be sure that they had it and were stocked up. So we certainly saw a spike. Mental health has been an area. I've got a separate slide on that, so I'll come back to that. But clearly, there has been a concern in terms of what is the impact on people being in lockdown for such a long period. With the reductions in referrals, we're certainly concerned. Have they actually been just building up in the background, and we're now going to start to see effectively a surge of sort of referrals and work coming in, which will create a different peak, which will equally be difficult to deal with. And on top of that, obviously the peak in the COVID was unknown at the start, and all we could really do was react to what the national modelling was showing, and hoping that effectively the social distancing and the lockdown procedures would flatten that curve, which thankfully it did. So just a little bit on the mental health services, which probably haven't attracted so much national attention, although they've certainly been there effectively on some of the news, but not so much as some of the frontline acute services. We did see a dramatic referral drop during this period. So we are concerned, what has effectively been the impact of that around areas like anxiety, depression, and are we going to see that sort of come back now with a huge sort of spike in demand in it? Overall, the actual activity levels that we were dealing with remained relatively flat, but that was effectively increased contact with existing mental health users. So, an unusual dynamic there in terms of a reduction in new referrals coming in, but an increase from the people that were already within the system. We did remain operational on a mental health basis throughout the whole process, and the ways to contact, again, trying to push out in terms of some of the crisis lines that we've got, offering the face-to-face if needed, but effectively, again, using some of the telephone and some of those sorts of supports to do that. And if we can use the digital technology, then that's been the way we've tried to do it. As the NHS started to see the flattening of the curve, we have sort of moved forward now with that, and we entered what was known as sort of phase 2. This was sort of a national sort of phrase, which was really looking at, okay, what services can we start to bring back online safely? Now, the impact of that, we've put there, at least a 12-month impact. It could be considerably longer than that. We just don't know yet. We are still, in effectively a major incident, and we're still in the height of a pandemic. There may be a second surge. There isn't currently a cure for this, and the vaccines that people are probably aware of at the moment are all still undergoing sort of trials. So, we just don't know at this point how long this will take and how long it will take us to actually come out and get back to sort of pre-COVID levels in terms of the actual procedures that we can carry out. So there is a balance there between, what is safe to do and what is clinically necessary to do, and that'll be on a patient by patient type basis. There has been a lot of positive that's come out in terms of some of the use of technology and the way some of the partners are working together. So, we're very keen to sort of keep some of that. As I said, we've tried to keep members of the public informed in this. There's been an awful lot pushed out through various media channels, and obviously people can't have failed. It's been it's been the leading item on the news probably for the entire the 100 days. There's not much really been able to move this. We've tried to mirror some of that locally with some of the websiting, some of the messaging, some of the social media channels to do that, and just linking in with a number of the sort of the local groups to do it. But as I said, it's been a huge effort from the NHS and its partners to do this. I think we've responded well to that, but clearly there are lessons that can be learned as part of anything like this, and we'll certainly need to reflect on it. But I wouldn't want anyone to sort of feel that we're kind of out of the woods yet. We're not. Councillor Orrell mentioned there, it's a game of two halves, and I think that's probably right. We are coming to hopefully the end of the first phase of this, or the first real impact, and we've seen it gone down. But so we still need to manage and deal with this every day in the NHS. We've still got to use all of the PPE, we've still got to use the social distancing, we've still got to make that risk recovery. And if we start to take down some of the partitioning to get back to normal, if a second surge comes, a lot of the stuff's got to go back in place and go back up. So there's a fine sort of balance to be made there. I think I'll pause there because I'm conscious there's probably quite a lot of questions around it, and we've got a number of NHS colleagues effectively also on the meeting who are happy to assist.
Thank you. Oh, I'm going to do that. Sorry. IT people, I've got a lot of people now. Okay, Tim, are you putting your presentation down?
Yeah, let me just.
Thank you. I think that's better. That's sorted out. Okay, I've got a whole series of questions or questioners, and I'm going to start with Councillor Nick Ireland.
Thanks, Chairman. Yeah, Tim, the reason I'm asking this is because I didn't see it in your presentations. You're probably aware that there was a bit of controversy, certainly in the Dorset Council area, about the provision of probably non-medical beds is probably the right description in the Hotel Rembrandt in Weymouth and the Grange near Sherborne. And the reason I ask is that when I asked Councillor Miller back I think it was on the 5th of May at Cabinet, she, in her response to a question on why it was being provided and the cost, she said that the cost was being shared between the NHS and Dorset Council. So I didn't see it on your list of responses. So could you clarify whether actually the CCG or one of the acutes actually semi-funded it, or was it purely Dorset Council, just for the record, please?
I'd have to check the actual mechanism around that, but there is effectively central COVID funding, and my understanding is, the local authorities are effectively going to rebill, effectively the CCG, who will rebill effectively the national COVID pot on that. So it's all going to a central national COVID pot. I'm not aware of the exact detail in terms of the actual hotel.
On that one, Tim, I believe that Tony Meadows will be coming on in due course for the council, and I think he'll answer that one. It's a more appropriate place for it to be answered.
Okay.
I can see Tony has put right to speak in the messaging. I don't know if you want to put him in now or later.
I think we'll come to that when we talk about those plans, and Tony can start with that in the beginning of his presentation and explain that situation. I have got a lot of speakers. John Orrell, I'm coming to you next.
Thank you, Chair, and thank you, Tim, for the presentation. Again, the NHS did well getting through it. Lots of changes, but again, the point is we're at half time. We can, as you say, we responded well, but there are lessons that can be learned. So that's the bit I'm really keen to pick up on. And the lessons I think we need to look at is the use of these Nightingale type hospitals, which were provided around the country. We thought we needed them. They weren't needed, which is probably a good thing. But we need to try and, what could we learn from this? What my point is that there were lots of people that came out of hospitals who were probably still infectious, even though they were recovering, and they went back to care homes. How much better would it have been if those people had gone into these empty beds, stayed there for a couple of weeks, made sure they were really better, and then gone back to the care homes, which would then have been successfully shielded. So I propose that as an idea for a better use of beds to protect our most vulnerable, because we didn't do well on care homes as a nation. It's not a Dorset problem. A second one is this, Richard Horton's just come out with his book, COVID Catastrophe, What Went Wrong and How We Can Stop It Happening Again. This is international, it's not aimed at England. Over in China, they use their hospitals called Fang Kang, I probably said that wrong, shelter hospitals, where patients who were ill went to those initially, and then from there, which took them out of the population. And then when they became, if any became extremely ill, they were escalated to ITU. So again, that's another use of hospitals, which in China worked to nip off their epidemic. Our use of Nightingale hospitals wasn't effective. So can we learn any lessons? Can we use these hospitals more effectively, either on the way in or the way out of the care process?
I mean, in the end, we didn't need the Nightingale hospitals for their intended purpose. So, we didn't set it up in Dorset in the end. But clearly, they were there getting ready for the critical care surge, and that was probably where we would have needed them. But my understanding is that those that have been set up have now adapted and changed effectively their approach really on the use of them, and that there was multiple proposals around the country. So some did want to use them as step-up beds, some want to use them as step-down beds, and it really depended at what point, I would say, on the timeline, were they actually being set up. So those at the start were very much, these are going to be needed for critical care. As that peak didn't really materialise and began to sort of flatten its way down, the NHS did respond and is using them for different things. So I don't think it was a hard and fast. There was quick adaptation on that, but we've not had one in Dorset, so it's not really been a conversation for us.
Okay, thank you.
You're muted, Jill.
Oh, it's not me doing it. I unmute it and it comes back off again. I'm Councillor LJ Evans, please.
Thank you, Chair. Two very quick questions, if I may. Firstly, you said the government promised whatever resources are needed, and it says in the report that the CCG has been spending about £1 million a month managing the COVID crisis. Local authorities were also told spend whatever you need and it will be reimbursed. Is this still the case, or are we going to be left with a massive funding gap for the NHS?
I mean, it's certainly still the case that we're working on that and that everything will get evened out during the year. I've got Nikki Rowland, who's the Chief Finance Officer on for the CCG. I'll invite Nikki in to give just a few comments perhaps on the latest position, but it's certainly what we're working to.
Thank you, Tim. Thank you, Chair. So the question for the NHS is, during the period month 1 to month 4, then yes, for the NHS, all the costs are definitely being covered still. And there are a range of processes that go on where we are able to charge both the provider side and the commissioner side those costs to through a COVID cost collection that goes through NHS England and NHS Improvement, and we get reimbursed for those. However, from month 5 to month 12, we are expecting an alternative financial mechanism to be put in place, but we've yet to see the information on that.
Thank you very much both for your answers. Is that okay, LJ?
So it's a kind of wait and see. That's not actually that reassuring, I'm afraid. But obviously that's all you can say. If I could just move on to my second question. As a GP, I'm incredibly concerned about the delay of care that has occurred for our patients during this crisis with respect to missed cancer diagnoses, long-term condition management, mental health you touched on. If the surge in demand coincides with the second wave, obviously we're going to be in real difficulty. Have we got the resilience in the system to actually manage both of those, please?
I mean, it's probably right for me to go to one of the providers on that, because obviously it's their staff that have been particularly affected by this. So perhaps if I bring in perhaps Debbie Fleming from Bournemouth and Poole Hospitals, and then perhaps Jane from the Community Services as well.
Thank you. So I think really going back a little bit to the point also about the learning, we have all learned huge amounts throughout this time, and there are some things that will be very helpful for us going forwards, some solutions that we found to problems, and also some that are still there. So at the moment, our challenge is how do we maintain enough capacity to cope with any spike as and when one might arise, but at the same time maximise what we're doing and not keep everything on standby with patients. And we all share your concern. I think our clinicians are hugely troubled and challenged, and we've been encouraging patients to come back to hospital. There was a statement out from all partners saying, you know, we're here, we're open. All of us are saying, please, please come in and get the care that you need. I'm pleased to say I was just checking the results, because we know that obviously things dipped an awful lot at the beginning of COVID in terms of the amount of activity done as patients stopped coming in for a whole range of reasons, and we had to close down some of our capacity. But it is encouraging to see how things have stepped up over the last quarter, as everyone has been trying very hard to bring as many patients in as possible for the care they need. And I would like to pay tribute to all clinicians, and that's GPs in the community care practitioners, everybody wanting to prioritise the most clinically urgent. And I think we've done a good job on that, although we're all worried about the backlog of those who might be becoming urgent. So our challenge now, and it's very live, how much intensive care activity capacity do we need to keep in Dorset to meet the need if there's a spike? And I think the model that we want to go with is not a Nightingale ward, but to make sure that across the 3 acute trusts that we're actually working together to say what will we do in the event of another surge, and that we can actually step up in perhaps one site that would be able to respond and specialise in that area. We have got problems with segregating off places safely. We have to have separate places in ED and in our admission units, and on our wards we can't have as many beds. So the amount of capacity we can open is limited because of social distancing and infection prevention and control. Key to our collective success is the really strong and effective community response, which we saw as we all got better at this. And again, there's learning on the way, but we don't need as many beds if we actually have got the right provision out in the community, and we've got the pathways to pull people through. So that's the bit I know colleagues are working on as well. And we have to make sure that we maximise all the best use of the technologies that we've learned, so that we don't go back to the old ways of working, but we actually are as productive as we can be through remote working. So it's quite a complex answer. It isn't all sorted out. It isn't all going to be fixed, as you'll know as a GP. It won't all be fixed immediately, but I think we are better placed to cope with a spike if it happened now than we would ever have been before. And what we want to try and do is to avoid that, and also in the meantime to not keep everything on standby.
Thanks. Can I bring in Jane Elson from Dorset Healthcare just to cover the community and mental health services?
Hello, thank you. Really very similar to Debbie, so I don't want to repeat a lot of what Debbie said. I mean, clearly it's going to be a challenge going forward in stepping up services and managing any surge in routine demand along with any other peak. And I suppose just really same things as Debbie, just to assure people, whilst obviously we have followed national guidance in terms of stopping some of the face-to-face work and outpatients, we have actually seen real innovation in some of our services in ways of working, and a big uptake in some of our services around digital offer. And so we've been able to maintain a lot of the services remotely and have planned appointments for people who do need to be seen face to face. And I suppose just in terms of some of those innovations, we've seen quite a lot of shift towards online work, group work, setting up rapid telephone lines for patients to be able to access if they've got concerns, with clinicians that are being able to man that. And equally, I think working in a very collaborative way with primary care, so it was alluded to earlier on in the conversation, actually working together and planning about how we plan for capacity and surges together and actually support each other. So I think it does remain very complex. It is challenging. We haven't got all of the answers, but I think we really have seen some rapid changes in the way that we do things that has allowed us to continue to provide services, and we'd want to continue to embed, because actually in some areas that has created more capacity to see patients, but it does remain a challenge. And equally for some of our services, we have shifted to seeing patients at home for people who have been shielded and things like that. Now, obviously, we continue to think about how we do that and support those people. But very similar to Debbie, ongoing challenges, but working our way through it.
Thank you, everybody, there for those answers. I hope, Councillor Evans, that's I won't say it's given you a huge amount of comfort, but at least it's hard work that's in progress. I've got 2 more people wishing to speak before I intend to move on to the next item on the agenda. And the first one of those is Councillor Bill Pike.
Thank you, Chairman. Good afternoon, Tim. Right, for those whose referrals and ongoing treatment was suspended, such as myself and others I know, when will their treatment resume? Debbie and yourself have both said, please come and see us, we're open. But my consultant says that they will contact me. So I assume this is what other patients are hearing. My still broken fingers await your response. Thank you.
Okay, should we, as we've got a consultant on the call, we've got Alistair Hutchins, who's the medical director up at Dorset County Hospital. Should we go to Alistair for that one? He can talk through the process, because it really is, as I said in the presentation, it's a risk versus benefit conversation. But I'll let Alistair run through it.
Thank you.
Hello, thank you very much. Yes, the problem is simply one of an increase in the waiting list. So in many specialties over the 3 months of the outbreak, we were not able to treat anything other than urgent patients, trying to balance the risk of bringing people in for important surgery, but not necessarily vitally urgent surgery, with the risks of coming into a hospital that had a lot of coronavirus patients in it. So in many specialties, the number of cases removed from the waiting list was negligible, and at the same time there were new patients being added to the waiting list. They weren't necessarily being referred in, but of course there was a backlog being generated. And so if you take a simple example where you might have previously had a 4-month waiting list, 3 months later you could have a 10-month waiting list, because you could have 3 months of undone work plus 3 months of additional patients added. So the way that we're approaching that at the moment is making sure that all of our clinical teams prioritise the patients who are most urgent to get back in. So particularly, obviously, things like cancer, heart disease, things where as time ticks by, the risk of serious injury being exacerbated increases. That, for somebody like yourself with a hand problem, that may be relatively cold comfort. All I can say is we are working as hard as we possibly can to look through our waiting lists, get the people who most need it most urgently, and at the same time look at how, particularly, for instance, using the private sector facilities, how we can keep going through, get through the routine work that we have to do. The other problem that we face is that everything's been slowed. So operations now take much longer because of the requirements of PPE. And that means that where previously we might have had a waiting list, we might have had an operation list that did 4 patients, now it's 2 or 3 patients. And so that's also slowing down our response. And so those are the problems that we're grappling with. And at the moment, there aren't any easy answers, I'm afraid.
Okay, can I just bring up one point which is related, Chairman? What do we listen to? Do we listen to the "we are open" part, come and see us, or do we listen to "we will contact you"? I'm not the only one here. There's others out there in the same position. What we listening to?
I think we are very much open for urgent and emergency care. and we're dealing with all of those patients in exactly the same way. But when it comes to the routine waiting lists, things are undoubtedly going slower across not just Dorset, the whole country, and in fact across the whole world at the moment. And that's a big problem for health services everywhere.
Okay, I get that. Thank you very much. Thank you, Chairman.
Thank you both for those responses. Then the last person to speak on this agenda item is Councillor Lisa Northover.
Thank you, Jill. I wondered about what sort of support is there or has been there and could be planned in the future for community pharmacists, because I know that they have been and probably still are completely overwhelmed with so many, particularly elderly people or shielded people, needing to suddenly get their medication delivered. Anecdotally, I've heard about people not getting deliveries of their medication in time, and also mistakes where perhaps with elderly people they haven't got the family around to pick up and check on the medication. So I wondered if that is something that came through in people arriving at hospital, or increased people coming to GPs and hospital. And I also wondered if there's anything could be done in the future to support those community pharmacists.
Okay, we've got Dr. Forbes Watson on the line, so perhaps I'll go to Forbes and ask him to give his views on that, just experience of dealing with the sort of pharmacists and the help we can do in the community.
Thank you, Tim. So at the start of this, as you've heard, there was a significant increase in the number of prescriptions generated. Patients were very keen to have as much medicine as they could, quite honestly. And there was a lot of pressure on GPs to support that. And of course, nobody was sure as they went into isolation how long they were going to be isolated for, and therefore were keen to make sure that they had stock. So it was a bit like the supermarkets. Pharmacies tend to run fairly independently, a large number of them. They don't have many pharmacists on site, and they also don't have a lot of space in their premises. So just the logistics of running a safe service was basically were a huge challenge for them. I haven't heard feedback about an increased number of mistakes. Of course, there are mistakes happen, and I haven't seen evidence that suggested that as a result of mistakes, more people are admitted to hospital. We can obviously look at that, but I haven't heard that thus far. But of course, anecdotally, you do hear of specific instances. I think the whole pharmacy situation has now stabilised quite a lot, and there's been a lot of joint working in terms of what we'd call wraparound care between general practice, community services and the pharmacists to deliver as safe a service as we can. And the voluntary sector was alluded to as well. They have really stepped up in terms of supporting pharmacy delivery and things like that for more isolated individuals. So I would say there was significant concern at the start. The other issue was the medication supply. Certain drugs were in short supply, so that was another problem that compounded what we had. So, but that all seems to have resolved itself. And I would say because we are working much more collegiately, then we're much better prepared for what we hope won't happen, but could happen over the coming months.
Thank you. Thank you very much, Forbes. Before you disappear, Forbes, I've got a question. He's coming back. I think he's coming back. You wrote in the chat about sufficiently trained numbers in the workforce and trained in the workforce for the beds and all the care that we need. I wondered if you could just very briefly, as chairman of the CCG, just explain if you've had a lot of staff who've had to become shielding so that they couldn't work, what the situation with that is. Also with the issues we have with staff who come from abroad and then haven't been able to come back and so on. Could you possibly just give us a bit of an update on what the situation is about staff in the area in the NHS at the moment?
Yes, as I'm sure you'll understand, workforce are paramount to delivering a safe and sustainable service. Workforce had significant challenges or have had throughout this, and certainly the outset. You've mentioned staff who required to either isolate or were actually off sick themselves. And that then complicates our ability to continue to deliver services or provide additional extra beds. So while you could build a Nightingale hospital and you could put X 100 or 1,000 beds or whatever was decided into it, you have to provide a workforce to support that. And what you mustn't do is denude your existing workforce to provide this workforce elsewhere. So there was a huge amount of planning went on in that regard. We very closely monitored on a daily basis through our SITREP process the absence rate for staff. That is now coming down quite significantly and now reasonably low, but not gone. And of course, the process of shielding is still impacting on. I don't have a percentage figure, but a number of staff, and we're now embarking on that process about a return to work for those staff. But again, it has to be where it's safe to do so. To complement that, though, we've had a large number of staff working very effectively remotely, and that equally has worked very well. So, some very positive messaging. And as Tim said in his slide, we've had staff who've worked in different roles in different parts of the system, just trying to address the need where the need was most at that point in time.
Can I just bring Paula Strobuck in, who's a Director of Nursing over on the acutes, to give a frontline perspective from the nurses?
Yeah, thank you, Tim.
Paula, thank you.
Certainly will be. I mean, it's been a great opportunity for our teams actually to work together, and they have absolutely risen to the challenge. So some examples: we've had staff moving across our trusts. We've had staff moving across departments to be able to provide safe care for our patients. For example, the staff in theatres have worked in ICU. So we've got really good processes working with directors of nursing colleagues across Dorset to be able to support each other.
We're happy. Are you back up? No. Is it working now? Yes, it is working now. Sorry, it seems to, when I'm not even touching the microphone, it seems to switch itself off. Thank you very much for that, Paula, and for your contributions, Tim. Tim, that was a very interesting report. Quite a lot of interesting questions there. Thank you very much for that, and also for the answers to the questions to the public I should be reading out later. Thank you very much, both of you. And obviously, I'm sure both committees would like to thank all of the staff in whatever capacity in the NHS or as GPs, and even in fact those people in the voluntary sector who have been helping deliver the prescriptions, for the amount of work that everybody's put in during this crisis. So thank you very much.
Thank you.
We're now going to move on to item 7 on the agenda, which is about social care and care homes. And for this, we've got a joint report. We've got Tony Meadows from Dorset Council and Phil Hornsby from BCP. But to start with, I'd like, Tony, would you just could you just possibly answer Nick Ireland's question, which was about actually how much money or where the money came from for the hotel facilities that were utilised? Thank you.
Thank you, Chair. Yes. I mean, to be honest, Tim Goodson did actually answer the question, that I was really just wanted to confirm the situation. So effectively, there is funding, obviously, that is allocated from central government. That is administered locally to support the hospital discharge process and that flow by the CCG. So effectively, yes, the council commissioned those resources. That has been put in our return, obviously, and submitted to the CCG, and they will be claiming that money back from central government.
Okay, that's great. Thank you.
Okay.
Yeah, we will have that minuted, and obviously, that should take that one. That's okay? I've had that on the chat from Nick that he's content with that. Okay. So would you like to go ahead with, I don't know if it's yourself or Phil who's... Phil
will be joining me. Effectively, we're doing a double act.
Oh, so you are?
Yes. And I guess before I actually, I've got a presentation that I will bring up, but before I actually bring that up, I just wanted to, I suppose, make a bit of a comment in terms of we've been talking very much about working together. And I think that's been one of the real positives, and it is good to find a positive from a very difficult situation. As a system, and we talk about system, and we throw that word around, but what does it really mean? And I think we've seen what it's meant over the past 2 to 3 months with the way we've worked together in a completely different way. So I'd just like to express my thanks to the colleagues that have actually been supportive in a lot of this work and actually helped me get through it, and obviously supported the system to get through it. So that is the CCG, that is the colleagues at BCP, that is Public Health. But also, I don't want to actually forget the providers. Our relationship with the provider market has really, really moved forward beyond what it ever was. They do now see themselves, I think, a lot more respected as part of a team working together. So it's just a little bit of preamble, really. I'm going to share the presentation with you now, but what you're going to see is actually the result of joint work. It's joint work that is actually being conducted not just by a local authority. It has been jointly produced by the partners in the system, and more importantly as well, those providers that are actually doing that frontline work with the people that we're caring for. All right, let's see if we can get this going up. Fingers crossed the tech works. I've got a blue wheel. I've got another wheel. Hey, here we go. No, that's the wrong one. I don't know why that's gone up, because that wasn't even open. Have you got it handy, Phil, to be able to share if I come off?
I think Phil's on mute.
I'll just do that now. Just give me a moment.
Okay. I knew that wheel wasn't going to do me any good. Thank you. Okay, in terms of context as we go through, the focus of this presentation is in essence looking at the response sort of since May regarding care homes, which have obviously been a significant area of focus. So if we can move on to the first slide, please, Phil, that would be great. A lot of this stems from the letter that came from the Ministry of State for Care in 2020, which was the announcement in the first instance of obviously some funding around infection control. But what it was also doing is focusing on creating some assurance at a national level about how local authorities and local system partners were actually working with residential providers through the COVID crisis. When I talk about residential providers, it's important to obviously remember what we're actually talking about here is not just older persons residential. We're also talking about learning disability and mental health, so registered CQC registered providers of any form of residential care registered. The requirement was that effectively local authority chief execs provided a sort of system assurance plan that, one, looked at what has been actually done in the system, and two, looked at what was planned to do in the future. In addition, what was actually implemented was there'd been a national care tracker, which is effectively a web-based approach to track how the resources in the care market were being utilised, so vacancies, etc. This has also been adapted to look at areas such as PPE, staff availability, and also now it's being utilised to look at outbreaks of COVID and those sort of scenarios. The situation we were obviously faced with on the 14th was this was announced. The care tracker also was adapted to start asking these residential providers a series of questions which would actually begin to give either assurance or highlight where there are areas of concern in in the local provision and local support, or indeed in terms of national interpretations of guidance, etc. If we can go to the next slide, please, Phil. So again, the key thing around this is that the plan was produced by system partners. Again, the tracker was utilised as a way of actually sense checking some of that. And the tracker really was looking to focus on areas such as the access to PPE, training, the ability to isolate residents and protect from infection, managing the risk of cross-infection, access to testing, availability of clinical support. It is fair to say that the questions were put together at haste on a national basis, and some of the interpretation of those questions was raised as an issue by us in our response, which you have got copied in the pack that was distributed. I think one of the key things as well is that we have to take into consideration when we're looking at these things, when you're monitoring the responses, they were looking very much at yes/no responses. There was no way for homes to actually look at anything a little bit more nuanced. So, for example, when we look at the ability to safely isolate a resident, well, in a home that maybe doesn't have a ensuite bathroom and they have to use maybe shared facilities from that point of view, and there are still some of those older homes around, then obviously those homes would have, regardless of their infection control, probably answered no to things. So it's very much a case of the lens has to be not necessarily looking for full marks, but using it as an indication of how the market is doing and using the intelligence it can gain. But if we can move forward, please, Phil. So the financial response also had to be detailed. So for this is very much from a Dorset Council's perspective. Phil will come on and talk from a BCP perspective very shortly. From a Dorset perspective, we increased all fees and rates in respect of all contracted care providers, care homes and home care by 10%. That was effective from the 19th of March. We were making payments to all providers. That was immediate upon payment, upon invoice. We'd got quite a lot of flexibility in our payment runs. We also had an open book offer where effectively we would offer to work with providers to consider any additional support if they were sort of finding that their cost pressures were above 10%. And again, from a Dorset point of view, whilst obviously, yes, there has been PPE that the council has administered and provided through part of the local resilience forum, we have provided approximately £2 million worth of additional PPE, which we've been providing through our local provision. And again, when just a shout out, bear in mind that a lot of that work has actually been undertaken by our highways department, who have been supporting communities and providers with those efforts. So again, it has really been a whole system approach. Thank you, Phil. If we can. So some of the things that we learned through this work in the capacity tracker was that about 84% of the residential care homes that responded actually felt that they had access to the correct PPE. Now, bearing in mind, this was a snapshot at the end of May, and I'll talk through what's been going on since then in a moment. 82% have confirmed they have capacity to safely isolate. And again, I've mentioned some of the caveats and some of the situations that could impact on that. Training and supporting PPE and the various medical pieces of medical equipment, such as pulse oximeters, etc., that may be utilised now and haven't been used before, maybe in care homes. Again, that's getting out there and it's hitting some good levels. But this is still a moving feast. 74% of residential homes said they were registered on the National Testing Portal. Again, this was a snapshot, but what it enabled us to do was to start working with those homes as a system to highlight where maybe the messages hadn't been understood, where extra support was provided, and to monitor that as it goes along. If we can move to the next slide, please, Phil. So this is just really to indicate how we are actually tracking this as we move through on a week-by-week basis. So on an ongoing basis, we're utilising this tracker to actually review these questions. So this wasn't a standalone report that we just sent back to the Minister of State and effectively that was it. We are going back and reviewing the performance against this to see if there's, as we bring out new guidance, is there a change to people's understanding, or if there's beginning to be issues in the supply chain with regards to PPE, or again, maybe if there's issues with regards to staff retention, for example, well, the access to training could become an issue. And it gives us an indication of over a large number of homes where we can see trends and where we can see certain issues. But again, the important thing is that this isn't just viewed from a local authority perspective. This is what we are working with as a system with provider representatives as well. Okay, Phil. And lastly, moving on to the Infection Control Fund. So this is obviously, if we go back to the first slide, we were talking about the £600 million that was issued from the government to be made available to support infection control. Initially, this was paid it's being paid in a two-phase sort of basis. So 50% was paid to the local authorities to distribute in June. Second phase will be being due during July. There are, with this particular fund, quite significant conditions. So 75% of the money received, so in Dorset's council, that was a circa £5 million in total, but 50% of that was paid to us first in the first tranche. 75% has to be paid to care homes. Can't be used for the purpose of purchasing PPE, but can be used for things such as additional staff to avoid staff movement, maybe some additional hours or those sort of things, cleaning, all of those sort of elements. The conditions on the 25%, the remaining 25%, it wasn't necessarily stated that it would be for care homes. And interestingly enough, as a provider group, we worked with, as a system group, we worked with providers to talk about how they felt that 25% should be spent. And it was highlighted that there's been a lot of focus on care homes, but there hasn't been a lot of support provided to the home care and the supported living market. So actually providers worked with us to actually look at ensuring that there was some parity and some support providing in that direction, which is what ourselves and BCP have actually done. So to date, in the first tranche, you can see there the figures. You will see that some people have actually declined. We've had 6 providers decline in Dorset. And it's always interesting when you hear of people declining money. Some homes have felt that the conditions that were actually put in place by central government that they had to actually commit to, and if they didn't actually commit to and provide the evidence to support their claim, it would have involved the money potentially being clawed back. They felt that they didn't want to go down that road. But as I say, 116, that's out of 125. 125 homes in the footprint, and that was administered, as I say, in approximately a fortnight. So again, a really good result from that point of view in terms of getting the money out in a very, very quick timescale. That's my part of it, Phil.
Can I just check if you've still got it on your screen? I lost my network for a moment. Have you still got it?
I have got it on my screen.
Well, that'll be good if I can keep it on mine then. Sorry. Is that scrolling through or not?
Not now, no.
No, sorry, I've just lost something at the moment and I'm trying to get it back. It's not helping.
No,
so I don't know.
Don't want it to, doesn't it?
Yes, it seems to have disappeared, Jill. I need to try and find it and I can't. So I'm really, oh, hang on a minute. Right, I've got it back. Sorry, apologies for that. So just reiterating what Tony's already said, as a system, you'll see a lot of similarities in what I'm about to present to you, because we did do this together, and that was helpful for our providers because they saw one message coming from both councils and the CCG. So, similar to Dorset's council's approach, we increased gross fees to all contracted care providers by 10%. Same date, 19th of March. We're about to review those as we go into July because we only had a certain amount of money for that. Again, making those payments as soon as we get the invoices in to keep the cash flow moving for providers. And that if exceptional costs were faced that were over and above the 10%, we were happy if they could provide the evidence to work with them to consider those costs. And the provision of emergency PPE in addition to the provision through the LRF. Similarly, when we looked at the National Capacity Tracker, it's a slightly different picture to Dorset's, but it is reflective. So almost 100% of care homes confirmed they had access to sufficient PPE. Nearly 90% that they could safely isolate residents, and 78% that they could reduce the movement of staff. And that's been one of the areas that we've focused on with providers to try and understand what more we could do to help them, what support we could give, even if it was just ideas and pointing in the direction of others providers about how they can minimise any movement of staff across multiple sites, or even sharing between hospitals and care homes. We've got some staff that work in both settings. Very similar to Dorset, so working with the CCG, there was training and support to PPE offered, and medical equipment, which just gave that ability to monitor remotely the observations of people's conditions. And a high number of care homes registered on the national testing portal, but still some work to do. So we do want to have 100% on that testing portal. So as Tony said, that was at a date in time on the 29th of May. And the funding that we've issued to care homes is out of a total of 3 million that BCP got, 146 grants to care homes out of 158 care homes in total. 12 declined. Just to put that in some context, 5 of those were specialist homes for younger people between 16 and 25 who had Asperger's or autism, and on a principle the homes were deciding that they didn't want to engage in the process. And then a couple of others who, for reasons best known to themselves, just decided it wasn't worth the trouble. And we're trying to work with them to understand more for the second tranche about how they might take advantage of it. And then in home care and supported living, we had 89 eligible providers, 73 have returned the claims. So we've issued just under £670,000 to date on them. So you can see, if you quickly totted that up, we've issued something in the order of 2.75 million. So we've still got 250,000 or so left over, and we've asked the Minister for Care if we can, in our response, if we can redistribute that money across the providers who do want to be engaged and continue to work with those that have said up to now they don't want to take part, to see if we can, because we are conscious that providers have been struggling to make ends meet. And then, just as Tony showed that point in time and the difference over the last few weeks, so you can see there that in the majority we've seen an improvement in the numbers in progress, in the percentage of care homes who say they do now meet all of those requirements that the government put in place. A couple of areas where we would think there's more we can do, it's around workforce, under the workforce support, about access to returning healthcare professionals. And then just it's getting better, and it's getting better by the week, the named clinical lead. And we know that the CCG is working closely through the primary care networks to make sure that people do know who their named clinical lead is and working with their community networks. Thank you.
Thank you, Phil, Tony, both of you for that report. I think one of the things we need to appreciate is that how fast this moved, because they may well all have said that, 70% of them are now at that stage whereby they can isolate patients appropriately. I'm sure that wasn't the case in March. And I think that actually one of the issues we had with the raging COVID through those care homes was actually, it wasn't so much the lack of attention, it was purely that they weren't aware that people were bringing that into a care home, and by the time they were aware it was too late, and then there wasn't anywhere to isolate people anyway. Now people of care homes have got themselves into a much better place where they, with the help of the councils, they understand what they need to do and how they can progress. It's extremely difficult to shut somebody who has complex dementia needs into a room, and you can't lock them in. So I think we do have to kind of remember that. Now, I've got a couple of people who are after speaking. The first one is Karen Rampton, followed by Councillor Evans.
Thanks, Chair. Can you hear me? Yeah. Yeah, it's just a question about the the apparent generosity of giving an uplift of 10% to the care home providers and free PPE, and there's an extra pot available of money in case anybody is struggling and needs it, and providing training and support. But I'm hearing that some homes have been charging self-funders an additional fee on top of what they pay to cover the cost of PPE. And that seems to me a bit like wanting to have your cake and eat it too. So I just wondered if there's a comment on that, please. Thank you.
I'll come back on that one if that's okay, please, Chair. You are absolutely correct in terms of there was a period where a number of local providers perhaps actually took that decision. Obviously, these are private organisations and we don't have direct control over them from one point of view. However, I know that in at least 2 situations where we intervened with the organisation and they actually withdrew that approach as a direct result, because obviously the funding in terms of that we provided in the first instance was only relating to the beds that we were actually procuring. The PPE was available across all, so obviously, and we are conscious that we do have a duty to support self-funders as well, and you know, from that point of view. The infection control money, again, was very, very specifically for every single bed that they actually have. And I think when we started having that conversation, very much that attitude changed. In terms of the additional support or any additional support that we actually provide anybody, our statement to a certain extent, both from BCP and from Dorset Council, has been very much that we will work with them. But obviously one of the key things we would consider is actually we need to see how they've been spending their money, what they've been spending their money on, and if they have not used the money appropriately or they have been double charging, etc. Obviously, we're not going to be looking to support them. We have to be realistic. This is still a tight budget that we're working with. And we want to make sure that there's equity, that we can support those providers where they do need it, and not necessarily anywhere they may be not utilising that funding in the most appropriate way.
Thank you, Tony. Phil, are you happy with that answer, or do you need to add anything?
No, I think Tony's covered it really well, and we've worked together on, as he indicated, around some providers. We've done joint responses at times, so we've made sure that the 2 councils haven't been at odds with each other, and we've included our CCG colleagues when it was appropriate to as well, so that the providers, some of whom work across both council areas, are very clear on what our position is, and don't think they can play one of us off against the other.
Thank you. I think that's really important. The next question comes from Councillor LJ Evans.
Thank you, Chair. We've heard an awful lot about care homes during the COVID crisis, which is understandable due to, as John said, 10,000 excess deaths, which is truly appalling. But I'd like to suggest that we also need to have a similar focus on home care and supported living. Domiciliary care is literally mentioned only on one of your slides and not at all in our reports. I would suggest they have similar vulnerable patients and possibly worse issues over cross-infection because they are literally travelling from one person to another. So I'd be interested to know, are they getting help and support in a similar way? And could you tell us a bit more about that, please?
Tony, should I start?
Do you want to start off on that one? And then,
yeah,
it could be either of us, couldn't it, Phil?
Off you go, Phil.
He's frozen.
He's frozen. Do you want to start then, Tony?
I'll start while he's frozen. Obviously the response that we detailed is obviously if you like, a statutory response. It was a request by the Minister from the Minister of State for Care, and was really focusing on care homes from that point of view. We have been cognizant all the way through that this is obviously an essential area in terms of home care and supported living. Home care, especially at the moment. I mean, we're seeing some significant changes in the home care market. Complexity and demand has increased very, very significantly. occupancy levels in residential care are obviously dropping because people are preferring to stay at home. And also, to be perfectly honest, this has given us an opportunity to work differently, because this is how we can promote a lot of the home first models and the idea that sometimes people have better outcomes with the right care and support in their own home. It's not to say that residential care doesn't have its place, but if that is the outcome we can achieve, I think we can fast track a lot of the work we've been doing around that. So we're definitely not ignoring it from that point of view. I think we had a lot of lull in terms of demand for care during the key peak, but we are working with providers throughout our processes. So to give you an indication, whilst in the crisis period, we've got the LRF structure, and below that we've got provider representatives both from the home care, residential care, supported living, actually present all the way through those structures, whether it be from testing, PPE, everything. So their voice is heard as a market, and we are acting with them. The focus that we've gone with today was really, this is something that's we've had to publish. And it was a feeling that this was a way of giving you some level of assurance to actually take everybody through, shall we say, each sector of the market, which we'd be more than willing to do at another occasion. I think it would have been quite a long agenda. But we are, please be assured, we are working with that sector of the market, because to be perfectly honest, it does give an opportunity to really change the outcomes for people by actually getting some changes done on that. And I think we're already working together on some of those initiatives.
Phil?
Well, I'll try again. I may be back, and if I don't last, I'm apologising already. Yeah, and I think the bit I would add is that the guidance and information that's come out from central government and public health around how home care agencies should operate and how they can protect their staff and the people that they support, particularly in use of things like PPE. And I happen to live opposite someone who's receiving quite significant home care at the moment, and I see very good practice in terms of the donning and doffing of PPE coming and going into that property, because it is important that they don't carry that infection between visits. I think it is a challenge for them, and it's a challenge for their staff. We've tried to support by things around how they transport around to avoid public transport. Some providers are using money for bikes, offering to run people around in their cars or through taxis. So I think it isn't an area that we want to just think is okay and forget about. There's quite a lot to do, but I think what we've seen, and as Debbie Fleming talked about, that the whole system support around helping people get out of hospital, our rapid response home care services have been fundamental to making that happen. So we haven't just relied, I think in the early days of this crisis, we relied on care homes too heavily, but we've shifted that emphasis back to those community providers of home care, and they are getting people home quickly, safely, and supporting them, and we will continue to work with them on that basis.
In addition, sorry, Chair, but in terms of infection control, the colleagues at the CCG supported the sort of rollout of infection control training to all care homes across the area. We've already started rolling that out as well to both supported accommodation, supported living, home care providers, also looking at personal assistance and people with direct payments to allow them to have obviously some awareness and some training of all the steps they can take in those ways as well. So this is an ongoing thing. It isn't a case of these are one-off interventions either. This is something that we've got to continue doing because, as we've stated in earlier sort of conversations, we are not resetting to the extent this has gone away.
Thank you very much, both of you. I think it's another interesting thought is that if less people are going to go into care homes, then we're going to need more people providing care in the community, and how we actually encourage that as a good job and a rewarding job for people, particularly some of those people who've been in hospitality industries and may not have jobs. I think we've got an opportunity now to actually do a bit of work in that area. I've got one final person to speak. Councillor Hazel Allen has to leave at the moment, so I appreciate the fact that she came. The last person to speak on this matter will be Councillor Andrew Kirby.
Thank you, Chair. I've slightly changed my question as it's been touched on so multiple times. We've sort of entered into every agenda item with ironically how positive the COVID pandemic has been, with the fact that we've all come together and acted as a team, and there's been a lot more partnership working. And Tim mentioned that, you know, over 25 years of working in healthcare, that this is the best it's ever been. However, I'm not trying to be facetious. I think that there has been some really good work going on. And again, moving on from Big Tim's point about the if I could highlight things like the discharge teams and how we managed to look at things like, you know, removing stranded and super stranded patients from the hospitals. And I know that at places like DCH that has been previously a real problem. So I think, you know, what I'd like to explore is that we've had all this good work coming through. We managed to empty out the hospitals very quickly, and I say the well people, I mean the stranded and super stranded people. And I'm not referring to the underutilized hotels that haven't come in. But how do we continue this good work and implement it now? You know, not just throughout COVID, but moving forwards. Thank you, Chair.
Thank you. Who would like to have a go at that one?
I'm happy to start, and perhaps others, including Tim, might want to come in.
This is a system answer.
It is a system answer. We do wish to continue the work, and we've already set up a group which is going to be called the Home First programme, which will concentrate on how we both support the acute hospitals to ensure that we prevent people going into hospital that don't need to, if we can support them and care for them in their own homes or in their community settings, with a multidisciplinary support, both social work, community health teams, GPs, etc. But also when people have had an episode in hospital, how we get them home quickly and we support them so that they get their assessment in their own place of residence, whether it be a care home or their own home, rather than in the hospital setting, which isn't really your natural environment and where you won't necessarily be at your best to understand your long-term needs. So we will do the short-term interventions and longer-term planning in the person's home, wherever that may be. And I think that is something that we've learned through this. We've tried to do this before. There's an opportunity presents itself now, and that engagement with our provider market that Tony referred to has really shown us that we can work together and mutually benefit from an approach where we understand what the needs are in its entirety, holistically, and then what our response will be as a system, which will also include how we bring the funding together to make that happen effectively.
Okay, thanks, Phil. Tony, do you want to add anything to that, or did that cover it?
I think that covered it, to be perfectly honest. It is the fact that you know, we are maintaining those approaches, and the key thing is we're maintaining that style of working that actually allowed us to deal with some of these things and actually find solutions a lot quicker than we were before.
That's great. I've got Vanessa Reed, who possibly could add a little more for us here, please.
Thank you very much. I can't
know what your actual title is.
It's Director of Nursing and Quality in the CCG. So I have responsibility for continuing healthcare, and obviously we've touched upon that already, that continuing healthcare assessments were suspended during this period. And I think it was Councillor Ireland, wasn't it, who asked the question, forgive me if I've got your name wrong, no it wasn't, where those assessments were suspended, they weren't taking place in hospitals, so there wasn't that a block that can sometimes appear in terms of who conducting an assessment. It was just a natural moving of people out of hospital by proactively going in and seeking those people who are medically ready to leave and taking them out of hospital. So Phil's mentioned already, the Home First Programme Board has been established over the last couple of weeks. The intention is that board continues the good work that's been achieved through the COVID response. So absolutely, we don't return to having those stranded or super stranded patients, that we have a way that we can move people out of hospital as soon as they're medically ready to do so, and move them to an environment where they would be better able to be rehabilitated and move on, perhaps to move home. or to a longer term residential setting. But the focus that we were clear on the programme board, it isn't just about hospital discharge group, it is around that principle of working together to keep people in their homes, their own homes, as long as possible as well. So again, it is following those principles that people have said already. It's a very joined up piece of work. We've agreed already a common set of principles and started to agree the scope of that programme that will progress at pace. We've appointed people into roles to take leads as programme managers. So we have put it on quite a firm governance setting, if you like, so that we have a clear oversight of the progress that group's making. So thank you.
Thank you very much, Vanessa. That brings us to the end of that presentation. Thank you very much, gentlemen, for that. I think it does actually give us quite a bit of assurance of the way that things have moved forward. I think Councillor Kirby was quite right. We have actually had quite a lot of good news stories come out of the tragedy that are for many people. But one of the things that has definitely shown us is that working as a whole system has to be the way forward. And what we mustn't do is we mustn't lose any of this momentum. We mustn't go back into our own little silos. We must continue to work, not just as a health system, but actually with the whole community. And I think that's really, really important. If anything else comes out of this and out of this joint scrutiny, that must be our recommendations as we go forward. So thank you for that. Now, I'm conscious of the time. We are ticking through. I have got, I'm going to take item 8 next, which is just, we need to have a protocol for both councils so that how we operate a health scrutiny committee in future, joint health scrutiny committee in future, so that we don't have to call all of the committees of both councils to that scrutiny. And so what we are suggesting is that is delegated to the chairs of both health scrutiny committees, along with officers from both councils, to progress that protocol. Is there anybody who wishes to object to that? Because if there isn't, I'm assuming that you all agree. Okay, fantastic. Then there are urgent items, and I have no urgent items. And there are no exempt items, but I do have questions from the public if I can find them. That'll be, I've got to go to a different screen. Here we are, I'm getting there. One moment. And I was really appreciative of the public giving us as much interest and questions. So I'm going to read through these. Some of the responses are relatively brief. And some of the responses, it's normal that we only allow 2 questions from each person, but bearing in mind there was so much public interest in this, as the chair, I was able to waive that in some cases so that we actually took more than 2 questions from a single person. So if you bear with me, I will try and read through these now for you. These answers will, of course, be sent to those people who have posed the questions. So the first question is from Claudia Sorin, and the response is from Public Health. The first question is, considering the advantages of local testing and tracing schemes as outlined above, and she did send quite a lengthy letter with this, which I couldn't read out in the time that we have. Will Dorset Public Health consider setting up a local scheme in Dorset over which they would have much greater control? The response is, we already work closely with the Regional Health Protection Team at Public Health England to respond to positive cases and their contacts. As local outbreak management plans are developed, and we've heard about those now, they were published yesterday, this will set out our plans to respond to cases and outbreaks in different settings, including local testing. The second question is, how does Dorset plan to manage, test, track and isolate? Again, this refers to the local outbreak management plan as to how Dorset Council and BCP councils and public health teams will work closely with Public Health England and their regional protection team to respond to positive cases and their contacts identified by NHS Test and Trace. It is published on the Dorset Council website, and also the link will follow. It will be on the BCP website. The third question is, the chair of the Health Select Committee commented last week that we do not know where about 2/3 of new infections are happening, so we cannot feed them into the test and trace process. What are Dorset plans for finding asymptomatic carriers? The response: testing for asymptomatic COVID-19 cases is carried out in healthcare settings and in care homes currently. This is identifying low numbers of asymptomatic cases. In addition, if there was any local outbreak, more widespread testing would be undertaken to identify whether asymptomatic transmission was an important factor. Question 4. How will those in insecure employment be supported to self-isolate? And the response: local outbreak management plans have been developed, we come back to those again, that set out how we will provide support people to self-isolate under different circumstances. This will be by extending the support offered by voluntary and sector groups to people who have been shielding. And I think also on that particular question, they may have been raising, was there going to be further money for those people? And of course, that is not a matter for the council or for the NHS, that is a matter for central government. Question 5, given concerns about asymptomatic carriers and the chair of the Health Committee's further comments last week that about 1/3 of new infections are people who have caught C-19 in hospital or care homes, A, are there any plans for regular routine weekly testing of NHS care staff, including those caring for people in supported living and in the community? And I think we've actually heard quite a lot about that during our meeting today. So the response is no, not at this time. And B, are there any plans for regular weekly routine testing of hospital inpatients and care home residents? And again, we've heard quite a bit about that. When is the appropriate time to test? Today they might be positive, that might be negative, tomorrow they might be positive. It's quite difficult to know. So the response is no, all hospital inpatients are tested prior to admission or on admission, and then prior to discharge if they are going into a high-risk closed setting, e.g. a care home or prison. Whole care home testing is available to care homes at this point, but there is, and then it doesn't say anything more on that, so I don't know where the rest of that one's gone. So there is. I think no intention to do this on a regular basis. Sorry, that was me jumping rather a large page. The next question comes from Lisa Weir, and the response is from the CCG. Could the Joint Committee advise what are the infection control plans to safeguard Dorset patients, older patients, patients with long-term conditions, BAME patients, mums-to-be and newborns, and to meet NHS England guidance of separating C-19 patients from other emergency patients during any future wave of this pandemic or any other pandemic? And again, we've heard quite a bit about how the hospitals have been operating and will continue to operate. So the response is, infection control plans have followed national guidelines and best practice. COVID positive patients have been separated wherever possible. However, with a long incubation period for the virus, this affects the testing process, so it's not possible to say that someone is COVID-free. Our hospitals use stringent universal precautions for infection prevention and control, including, but not restricted to, PPE, social distancing, increased cleaning and decontamination of equipment. Emergency patients are segregated on admission, and there are processes in place for elective patients to test and shield prior to surgery. In primary care, we have created hot and cold sites to separate people who are suspected of having COVID-19. We will continue to provide electronic consultations where practical to prevent unnecessary visits to healthcare premises. Thank you. The next set of questions come from Chris Bradley, and again our response from the CCG. In any future waves of COVID-19, or indeed any other pandemic, could the Joint Committee advise what will be done to ensure, number one, we have enough acute and critical care beds to cope with a second wave of COVID-19, or indeed any other pandemic? Current planning indicates that there will be no emergency care beds at Poole and 74 less acute beds at Dorset County. Although beds at Bournemouth Hospital will increase, there will be 245 less acute beds over our 3 Dorset hospitals. And the response is, the future plans for East Dorset has more critical care beds than the current provision. No health system is permanently established to cope with pandemic level of service requirements. Hence why the Nightingale hospitals were induced to cope with surge in demands elsewhere. Second question is, do we have enough acute beds to maintain planned operations? And the response is, the halting of planned operations was a clinical risk judgment. And again, we've heard quite a bit about that today. Balancing the benefit of procedure versus the risk of catching COVID for both the patient and NHS staff. Emergency procedures and being prepared for a surge in very ill patients with COVID took priority for beds due to the potential for large numbers of patients requiring them. Services requiring no beds all took a similar approach, similar to the dental services. Question 3, no one who is infected is either discharged from acute hospital or admitted from home into a care home. And the response is, national guidelines were followed in relation to discharges. However, with a long incubation period for the virus, this affects the testing process. So it's not possible to say that someone is COVID-free. Hence, PPE and distancing measures are used for all patients. All patients leaving hospital going to a care home and admissions to all care homes are tested for COVID prior to admission. Question 4. There will be timely access to adequate PPE for carers. And the response? National guidelines were followed in relation to PPE. And again, we've heard quite a bit about that in our meeting today. Question 5. Could the Health Scrutiny Committee, Joint Health Scrutiny Committee, also advise what plans are to resume planned operations, what the backlog is, and when it is expected that we will catch up to where we were before the pandemic, given that even at that time people were waiting much longer times for planned operations than they were, say, 10 years ago? And the response, again, we questioned this ourselves in the meeting. Planned operations are gradually resuming, but this remains a clinical risk judgment, balancing the benefit of the procedure versus the risk of catching COVID for both the patient and the NHS staff. PPE and distancing measures remain a factor for stepping services back up. It is too soon to say when the NHS will have caught back up with the pre-COVID position, especially considering we are still in the pandemic major incident phase. And that brings me the end to the questions and answers today. Sorry, we have run over by about 15 minutes, but I think it was worthwhile having that conversation and asking those questions, because we do seem to have got through quite a lot today. All I can say to everybody here is very best wishes. I hope you all keep safe, and let's keep our fingers crossed that we don't have another spike and that we can continue safely working our way through in Dorset. So thank you very much for everybody who's come today. and thank you very much for all the staff who's put in so much hard work for this. So that's the end of the meeting. Thank you. Bye bye, everybody.